All right, welcome everyone to the next edition of our webinar series through or brought to you by the Medicine-Rehab-Fitness Institute, www.mrfinstitute.org, and there will be a slide at the end with a QR code and URL that you can uh, check out. But yeah, so I'm excited for this webinar because obesity care is a huge passion of mine, and this is a great case study. And it is titled Interprofessional Collaboration, the Role of Exercise in Obesity Care. So my name's Jeff Young, and I've introduced myself at other webinars, so I'll keep this real brief, but I'm 30 years into my career from an obesity standpoint, or obesity care standpoint. I've been staff at Duke University Medical Center's Diet and Fitness Center, as an educator at UCLA Medical Center and Beth Israel Medical Center's Diabetes Institutes, and then at Mount Sinai Medical Center's Center for Health and Healing here in New York City. So in all those cases, the programs either revolved around medical weight loss or included medical weight loss. And so, yeah, I'm excited about this. And I'm going to let Sheila introduce herself, and then I'll put up the PowerPoint presentation, and we'll get started.
Sounds good. Thanks, Jeff. So I'm Sheila Hautbois. I teach at Shenandoah University PA program in Northern Virginia. And I do that full time now, but still have 1 day a week for clinical release to continue practicing. I've practiced in cardiology, lifestyle medicine, and have done some obesity medicine as well. Today's case is going to be a cardiology-based case, so it was based on a real patient, but I've changed a lot of the identifiers so that I don't think there's any way that anybody would identify the patient. But if there's any way you do, uh, keep HIPAA in mind. I am a fellow of the American College of Lifestyle Medicine, which is a great honor. There's very few of us, and so I have a great respect within the field of lifestyle medicine, and I really love bringing attention to the exercise pillar that is in common with the obesity pillars as well as the lifestyle medicine pillars. And I think that's all I'll say as an intro.
All right, let me do the share screen. And so, yeah, so I'm Sheila. I'll just click through at your pace. So
Okay.
I'll go to the first slide, and you can do your thing.
Okay, so I wanted to present a case study tonight. We'll call her Jane Doe. She was a 66-year-old white female who came into the cardiology office for a follow-up after an ER visit for palpitations and chest pain. Her history was hypertension, type 2 diabetes for 8 years, some high cholesterol and triglycerides, fatty liver but without fibrosis. Gallstones were found incidentally on imaging, and she had had a left knee injury of some sort about a year ago, had some arthroscopic surgery by ortho, outpatient, and followed by PT for a while. She was on a couple medications, so one for her cholesterol, one for her blood pressure. She was on a acid medication for reflux, the glipizide for her blood sugars, a multivitamin, and some Tylenol as needed for any joint pain. She was allergic to aspirin, so that's why she wasn't on that. And no smoking, no drinking, no drugs. She was trying an Atkins diet that her gastrointestinal specialist had recommended. She was down to 1 cup of caffeine a day, down from higher than that, and significantly was doing absolutely zero exercise. So she was 5'5", 186 pounds, which gave her a BMI of 31. You can see her blood pressure was just slightly elevated in the practice. Respiratory rate was normal. Pulse was on the high end of normal, and she was saturating well on room air. Physical exam was remarkable only for obvious abdominal adiposity and a little bit of swelling in both lower extremities. We did an EKG in the office, and it was basically normal, just a little bit of a left axis deviation and left ventricular hypertrophy, both consistent with the hypertension. So we ordered an echo like all cardiology practices would do, and we found her ejection fraction was good at 65%. We also did a carotid intima media thickness, which measures the thickness of the artery walls in the neck. And that showed a vascular age of 84. And remember, she was in her 60s, mid 60s. So vascular age of 84, we were like, oh, and that was probably high due to the hypertension and the fact that she was not exercising. Good thing was she didn't have any significant narrowing of the arteries, and she had decent flow in the vertebral arteries. So we did a nuclear stress test, and we didn't find any EKG abnormalities during that test. Her ejection fraction was consistent with what had been found on the ultrasound. We did see a small fixed defect in the left circumflex area, probably due to an old scar, but overall this was low risk because there were no reversible defects found. We did on the treadmill, we were doing Bruce protocol, and she only lasted 3.24 minutes um, before her heart rate went from her 81 starting to 130. So the computer estimated that at 7 METs. And I wanted Jeff to just chime in here.
Yeah. So I live in New York City. Sheila lives in Virginia. I don't know who this patient is, and Sheila just passed on this slide deck to me days ago. So when I was going through this, I found a lot of this stuff from my standpoint to just be really interesting and intriguing. Like for instance, and I don't work in cardiac rehab. I've worked in stage 3 cardiac rehab for a little bit. So I am definitely familiar with some of this language, but I just found it really interesting, like what seems like a mismatch between her heart health and the rest of her cardiovascular, the health of the rest of her cardiovascular system. That her heart, generally speaking, isn't too bad, with the exception of some left ventricular hypertrophy. But in any case, as it relates to this slide, the Bruce protocol, each stage is 3 minutes, and stage 1 is at an intensity of 5 METs, which, if that's your capacity, that's really low, and that's not good at all. So it's basically saying that your heart and your respiratory system and your muscles are very deconditioned. She only lasted 15 seconds into the second stage. So the second stage is at 7 METs. Just for whatever it's worth, I disagree with the computer's conclusion that her capacity is at 7 METs because she only lasted 15 seconds into it. What that actually tells me, and also the fact that she reached a peak of 130 beats a minute, which is 85% of her max, it means that as soon as she shifted from stage 1 to stage 2, she also went beyond the second lactate threshold and was exercising anaerobically. So this was no longer aerobic exercise for her just after one stage. So I actually would say that her MET capacity was probably more like 5 or 6 METs. And the only reason why it says 7 METs is because she did at least make it into that stage for 15 seconds. And even though you haven't said anything regarding that last part of the slide, since I'm on the topic, let me just say that to me it makes sense that she expressed concern regarding fatigue because she was now exercising anaerobically, and she didn't have the capacity for that. I was actually speaking with Sheila prior to us recording and saying, even though I don't know who this person was and wasn't there, I would bet the bank that she was really feeling it in her calves, like a burning sensation. So it makes sense to me that she was expressing fatigue because that was a very novel experience for her. So it makes total sense.
Yes. And we were concerned too because her blood pressure was going up in response to the exercise, especially right after she hit that 3 minute and we increased the uh, strain. Okay, so the plan for Jane Doe, I basically think about this in a couple different quadrants. The first quadrant is medications. So I considered adding a beta blocker for her based on her heart monitor, her chest pain, her old scar, her hypertension, and those bothersome palpitations that she had gone to the ER for. I know that beta blockers can be associated with weight issues. But in this case, I probably would start at the very lowest dose, and I think the pros here outweigh the potential con. I would also order labs for her for fasting blood glucose and A1C and see how well controlled that is, and consider switching her to something like metformin from the glipizide. She's 66, so it's doubtful that she would get a GLP-1 right off the bat without trying it first. And I don't love glipizide, especially for patients who are going to start exercising, because it's going to be pumping out insulin at random times and can cause some low blood sugars. And I don't like to pass a patient along to an exercise specialist who is going to have the potential of going low blood sugar. From the
Oops,
second,
sorry.
oh, go ahead.
Sorry about that. Go ahead.
From the second quadrant, it would be the behavioral modification piece. So when talking to her at that first visit, I would do a brief screen for any kind of eating disorders, depression, anxiety. Those are like 2 questions each. Sleep apnea is a couple questions. Stress, a couple questions. We talk about mindfulness, and I would be able to provide any referrals to behavioral counseling or anything to follow up on any of these areas as appropriate. And then the third piece would be the nutrition piece. Again, a quick assessment there to find out when is she eating, how many meals a day, snacks, what types of things is she choosing. My mantra is the 2 Ps method of meal planning, which is ensuring we have protein and produce at every meal. Those are the 2 most important things, and then we can add some starch onto that. Continue focus on cleaning up the diet, avoiding ultra processed foods, and ensuring that fats are healthier fats. And here I would consider referral to a dietitian for personalized, tailored education and guidance. And then the key piece here is the exercise piece. I would do an assessment exercise as a vital sign. I knew in this case she wasn't exercising at all, so I didn't really have to ask how many minutes a day are you or a week are you exercising, how many sessions, how much strength training. For her was 0. So this was easy assessment. So in this case, referral to a qualified fitness professional for a personalized exercise prescription could be very helpful.
So I'm going to take over from here, but before I do, I actually want to go back a couple slides and just make sure that I note that 7 Mets is, at least from like a research standpoint, is generally considered to be that cutoff. If you're below it, that's considered very deconditioned, and that for her age, someone who's healthy and fit, at least to some level, it would be 8 to 10 Mets would be the norm, and that's and the truth is, but that's very achievable on a progressive and the right uh, exercise program. So with that in mind, I'm going to now take over with executing the exercise prescription. Please understand this is purposely very high level because this is just a webinar. So I'm just going to go over these very quickly and then hope that we have a discussion afterwards where as I move through my slides, if you have any questions, please write them down so you don't forget it, and then we can go back and discuss any particular points. But I'm not going to be diving deep into any of these slides. And what you're getting ready to see is that there's really an algorithm that fitness professionals should follow from a best practice standpoint, and there's 6 steps, and you're getting ready to see the steps as I go through them. So I also wanted to quickly say before I get to the main slides is that part of this whole collaboration is, at least from a fitness professional standpoint, we need to build trust with clinicians. And I co-authored a recent article, was a feature article in a special edition of the American College of Sports Medicine's Health and Fitness Journal. It was their September, October issue. So it was just not the current issue, but the last one. Uh, Titled, as you can see, Developing Trusted Collaborative Relationships Between Healthcare Providers and Exercise Professionals, with Dr. Amy Bantham, who's the immediate past president of an organization called the Physical Activity Alliance, and Dr. Matthew Campert, who's at the Cleveland Clinic. And I'm also going to be on an expert panel talking about this at the ACSM's National Conference in March. So this is something I'm really passionate about, and as you'll see as I'm going through my slide deck. So step one is the initial collaboration between the fitness professional and the referral source. And since this is recorded and we're going to have it up on our website, for any fitness professionals who end up watching this, step one is to thank the referral source. I know it sounds like common sense, but you just need to do it. You need to thank the referral source every time you get a referral. They are positively affecting your livelihood. So I want to at least put that in there. And then, just like we've been discussing and Sheila's been reviewing, learn the information about the patient that's pertinent to the exercise prescription. This is going to include indications, precaution, and safety modifications, and contraindications to exercise, which I will go over in a little bit of detail at the end of the slide deck. And in this case, since the patient had previously had physical therapy for her knee, the fitness professional should, that should make note of that and consider connecting with the physical therapist as just not only for more information about the knee, what were you doing, what was happening at discharge, it, what do you think I should be doing from an indication, contraindication standpoint, but also just to be able to connect with another clinician because it's another potential referral source. So that's step 1A. Step 1B is the actual connection, where ideally the clinician is going to help initiate the connection. It's either going to be in person if the fitness professional happens to work in the same clinic. And in my experience, the best referral sources I had would take the time to step out of their office and come and see me and say, Jeff, do you have a second? I want you to meet a patient so we can get that face-to-face connection. So incredibly important. So whenever you can get a face-to-face connection, that is absolutely ideal. It really increases the likelihood that the patient is going to follow through with, at the very least, the initial consultation. Or you can do it through email. And since Sheila refers patients regularly and we don't live in the same area, she has a script that she goes through, which I'm going to have her quickly talk about.
So basically, I my practice is a little bit unique in that we use email with our patients. They all sign a HIPAA waiver to be able to communicate through email, and our email is HIPAA compliant. So I realize most clinicians are not emailing their patient, but we're in a concierge practice, and that happens. So essentially, I will email the patient and Jeff and connect them, and just basically call it introductions. And I've told them in advance, I'm going to be connecting you to Jeff Young, a medical fitness expert. So then in the email, I basically just write, I'm here connecting you to, Jane. This is the medical fitness. Jeff is the medical fitness expert that we talked about in our visit today. Jeff, Jane would like to talk to you about her health goals and how you can help out. Please send her more information. Best. It doesn't have to be that long. I don't put anything real specific in the email, like no, health information. We can talk offline about that with the health professional, but I'm not going to put that right in an email.
Yeah, and from my standpoint, I just love it. I love when I see because it's the same script or almost the same script. It's like 90% the same every single time. And it just shows that this can be very simple. It doesn't have to be challenging. And Amy Bantham, who I just mentioned, the immediate past president of the Physical Activity Alliance, she did her doctoral dissertation on this topic, which included the referral schemes. And there, unfortunately, today we don't have the time to go into a deeper dive. But just to give you an example, what they did in the data that she was collecting for her dissertation, they would actually write out a prescription so that kind of mirrored because that's a language that they get familiar with, and they liked having that written prescription. So in any case, there's different things that you can do, but the more you mirror what they are used to or familiar with in a clinical setting, the more likely they are to actually follow through with the consultation and the fitness sessions. And obviously, this is the goal. The goal is to try to increase the likelihood for physical activity and exercise. So that's step 1. Step 2, and let me actually just say that the algorithm now is once you've done all this communication with a fitness professional, and between the fitness professional and the clinician, the referral source, then it's screen, assess, design the initial program, progress that program, and follow up with the clinician. So that's the algorithm that I'm getting ready to go through. So step 1 is perform the initial screen. From a fitness professional standpoint, and you should know this as a clinician because if you're working with fitness professionals, you should be ensuring that they're using this is the 2023 version, but it's the physical activity readiness questionnaire. It's just 7 screening questions, yes or no, that you can see there. I'm not going to read them all off, but you can read them on the slide deck. And if he answered yes to any one, then that's a significant red flag, and the person's going to need medical clearance, period. So that the fitness professional really needs to start with that. And then it's important because there's a lot of fit pros out there that aren't. So you need to be aware of this. And another thing you should be aware of is that there's an algorithm, and the algorithm includes, I should say, a health screening algorithm from the American College of Sports Medicine, and it includes two uh, sections, two components. The patient or the person is either exercising or they're not. And as you can see from the table there, if they're even if they're not exercising, if they're apparently healthy, and have no signs or symptoms of cardiovascular, metabolic, or renal disease, then they don't need medical clearance. They have no signs or symptoms. They're apparently healthy. They can go on a light to moderate intensity exercise program and progress from there. And then obviously, if they're exercising and they're apparently healthy with no history or signs and symptoms, then do your thing, exercise, progress. But if someone's not exercising and they do have cardiovascular, metabolic, or renal disease, but they're asymptomatic, um, they should obtain medical clearance before initiating a structured exercise program because they aren't exercising. But for exercising individuals, if they even if they have known history, they're already exercising, so they can keep exercising as long as they're being put on a safe program, which I'm getting ready to describe. But if on either side, if they're symptomatic, they obviously need to see a clinician and they need to assess that, find out what's going on, and get medical clearance. So I just want to make sure that you understood that this algorithm exists and you should learn it even better so that you're really familiar with it. And then after what I do, I'm gonna be describing how I go about things, which is I'm biased to say is best practice, and that is they also fill out an intake form. It's my intellectual property, so I'm not going to completely share it, but I am going to give you some insight. I created a pretty extensive. It is a long form, but it's worth it, and it asks questions that dives a little bit deeper into their behavior with exercise, their mindset concerning exercise. Even if they had history of working with a personal trainer, I have questions on it about that because I just want to know, was it a good experience? Was it a bad experience? What did you do, etc. I have questions on the intake form that dive deeper into their fitness capacity, not only their objective that gives me a much so there's objective questions that help me more closely approximate their aerobic and strength fitness level, very closely approximate so I can get a strong idea of because fitness lies on a continuum. They're either beginner, intermediate, or advanced. And these questions, the objective questions, will really let me know what category do they fall in. And in most cases, it's going to be beginner. But there's also subjective questions that give me that what do you perceive your fitness capacity to be? So there's some questions on that. And then I also have questions that dive deeper into if they are exercising, what does your program look like? What is the frequency, the intensity, the duration, what type of exercise, the weekly volume of exercise, and how are you progressing? In most cases, I know what the answer is going to be. It's going to be suboptimal. But what it does is it just gives me more insight as to what they've been doing, and it gives me a sense of how extensive their exercise makeover is going to need to be. And then I also have questions regarding how do your medical and or musculoskeletal conditions affect you when you're exercising and your activities of daily living. So it isn't just about that par Q that I mentioned on the previous slide. It's also about getting deeper into the detail with these screens. Are you passionate about bridging the gap between medicine, rehab, and fitness? At the Medicine-Rehab-Fitness Institute, we provide in-depth resources to help clinicians collaborate with qualified fitness professionals and optimize exercise for everyone. Head to www.mrfinstitute.org to explore our full course on moving patients through this pathway and learn how you can add lifestyle medicine or medical fitness services to your practice. Visit us today to dive deeper into the future of exercise as medicine. From there, it's time to perform assessments. And since this is just a webinar and it's very high level, I'm not going to go into any real detail. I'm just going to let you know that I always perform a joint range of motion assessment so I can find out where they are tight, where their joint is moving normally, or joints, I should say, and where they might be restricted. I'm sorry, where they might be hypermobile or loose. This is a missing link. We need to find these things out in order to put this person on a proper flexibility program. But not only does it help me with a flexibility program to design a proper flexibility program, it gives me a sense of, like, for instance, maybe with the shoulder, and as I'm moving them through the range, I might start to see like a look of strain on their face or some clicking going on or something like that. Or one side moves normally and the other side doesn't, or something. So it'll show me asymmetry. So there's a lot more to it than just the flexibility program. But I always start with that. And then with aerobic, what most people are going to recommend is like a field test, like maybe a walk run or a 6 minute walk test or something like that. And what I actually would rather do, and what I prefer to do, is just use rate of perceived exertion, rate of perceived effort. I just want to find the person's start point. So for example, I might just put them on a stationary bike, start them at level one, at the lowest RPE we can go before the bike turns off, which is typically 50 RPE, and I'll use RPE scales. How does that feel? So I have them go at that very low intensity for like maybe 2 minutes, and I'll monitor their heart rate, and I'll just get some feedback from them. How does this feel? And if they're like, yep, this is pretty easy, etc. And I'm also doing the talk test to get a sense of their ventilation. And if I can tell and they're responding that this is fairly easy, then I'll move it up to level two, etc. But I would rather just use rate of perceived effort to find their start point, and especially in this case with this person, they've already shown that they are very deconditioned, and by the time they even got to a 7 RPE, that was it. They terminated the protocol. So, and then it's also the same with strength testing. With this, pretty much with anyone, I'm not going to do repetition maximum testing because it's asking them to put in full effort. I'm not going to do that. I'm going to just use what's called a familiarization phase, which I'm getting ready to briefly talk about, as a way to just meet them where they're at and find their start point. And then, yeah, I can do balance and mobility uh, testing, but I personally am going to do that during the what's called a familiarization phase. And ultimately, it's not really going to affect my programming a whole lot, just because in order to improve balance, you need a foundation of strength. And in order to improve mobility, you need a foundation of flexibility. So that's going to be part of the program anyways. And then it will just those two things will just naturally improve just by improving strength and flexibility. So the point here is, will the assessments change the design of my program? Not a whole lot. Maybe not at all. And even if it does, it's not going to change a whole lot. In most cases, assessments are going to just tell me what I already know and have learned from, in this case, Sheila, the initial consultation and just talking to the person, and also the initial screens, especially that long form screen that dives a lot deeper. So I'm already going to know that this person is unfortunately deconditioned, and that we need to find their person's start point, meet them where they're at, and progress in small, tolerable increments. But that joint range of motion assessment is really going to help me guide the flexibility assessment, etc. So that's the screen. Step one is we got to screen them. Step two is we assess, and step three is we assess, and step four is we got to design the initial program to meet them where they're at. And the gist of this, and again, I'm not going to dive too deep into this, but what I like to do is mirror physical therapy. So what happens in physical therapy, I think, is a great start point, in the sense of, let's have the frequency low, the volume is low. In other words, how many sets they perform per muscle group, keep that low. Keep the intensity low. Let's just keep it warm up sets, and even keep the variety low. Let's just have like 2 or 3 exercises for each major muscle group in the body as a start point, and we'll work with them on what the appropriate exercise selection is. So it really mirrors what goes on in physical therapy, with one exception. In physical therapy, they're going to be mostly working on the part that's injured, the shoulder, hip, knee, whatever the case may be. In this case, it's a total body workout, because this is not physical therapy. It just mirrors what's going on in physical therapy. But we're going to use this phase, which typically, in my experience, lasts for about 3 to 4 weeks. But in this case, it might be longer because she's very deconditioned. But we'll talk about that a little bit more in a second. But I'm going to use this stage to meet the person where they're at, meet Jane Doe where she's at, find out what her pain-free range of motion is, determine the appropriate exercises for her, make sure that, that nothing that she's apprehensive about, teach her proper form and the names of exercises, use these effort scales to determine her starting weights and the rate I'm going to progress her. Tons of cueing is going to be going on to help create mind body connections. And I'm doing all this to help her develop trust in me, to know that, okay, he's not going to get to work me too hard here, and in the program, because people are justifiably apprehensive, especially when it comes to resistance training, are apprehensive that they're going to get injured. And by doing this, they realize really within the first session, oh, I'm not going to get injured. This actually feels pretty good. So that's the whole purpose of the initial program design. This is a 3-week example, but again, in this case, I might extend it to 4, 5, or 6 weeks. So there's going to be a coaches and clients decision. But generally speaking, in week 1, it's two non-consecutive days, so it might be a Monday and a Thursday, 2 to 3 sets of 10, just like they do in physical therapy. I'm going to start at a 5 rated perceived effort, which equates to a warm-up intensity, and they would describe the last repetition of the set as moderate. With this person, I might actually start, and I probably would actually start the first session at choosing loads or choosing weights where she describes it as light. Because of how deconditioned she is, I actually would probably start at a 3 or 4 RPE in week 1. Move her to a 5 RPE, which is still a warm up. It's only moderate by week 2 or 3, and then move to a 6 RPE. But the whole point here is that you want to start low. I've learned from experience, whatever you think erring on the side of caution is, err even more on the side of caution. So, I've absolutely. So it isn't going to hurt anyone to start really, really light for those first 2 sessions. At least that way, you know that, oh, we didn't flare them up. They aren't sore, all that stuff. And then we can progress them. So that's the main point of this slide. What pace you do this at is up to the situation, but you start low, you move them to moderate, and eventually, whether it's week 3, 4, 5, 6, or 7, you get them into what's called the lower end of a working set, where it is starting to feel hard, and they are starting to get that look of strain on their face and all the associated things. From there, now once they get to that point where they can have the capacity to tolerate a true working set where things are starting to get hard, and you're starting to see that look of strain on their face and the speed of the movement slowing of the exercise, then it's time to progress them. And the way you progress is, number 1, you have a plan. The plan should be what's called periodized, which just means that it needs to be a structured plan, and you need to go in phases, which I'm going to get to in the next slide. And it also needs to be progressive. It needs to improve all aspects of fitness. And what I mean by that is, with everyone, it doesn't matter who you are. It doesn't matter if you're an athlete. It doesn't matter if you're just looking to improve fitness. It doesn't matter if you have medical conditions or musculoskeletal conditions. We all, throughout the entire lifespan, want to improve conditioning because we don't want to be deconditioned. We want to improve strength because we don't want to be weak. We want to improve power. That's not just for athletes, that's for everybody. Because even things like catching yourself from falling, you need power and quickness. Power is basically the ability to express your strength in the form of quickness or speed. So that's what power is. Taking your strength and expressing it in the form of quickness or speed, like catching yourself from falling. And then obviously we want to improve lean muscle tissue. So we need to have a plan. We need to log the plan. We need to periodize the plan, which I'll get to in the next slide. And then we need to choose the right plan for the person in front of us. So before I get into the next slides, the American College of Sports Medicine has a textbook. They have several textbooks, and one of them is called Exercise Management for Persons with Chronic Diseases and Disabilities. And they correctly say in this textbook that we don't need to design programs that are condition specific. In other words, we don't need to design one program for a person with hypertension, another one for a person with type 2 diabetes, another one for a person with knee pain, et cetera, et cetera. And the reason why is because most people don't conveniently present with one condition. They present with multiple conditions, as represented by this case study. And it actually is very confusing and unnecessary to do it that way. So you're getting ready to see how you go about it. Since we don't do condition specific, what does that mean? How do we go about it? Here's how you go about it. And remember, this is a webinar. It's very high level. Your questions, we can dive deeper into this, but I purposely just put one slide on this, or maybe just a couple slides on this. The gist of this is, you start with what I already said. You start with a familiarization phase where you determine the person's pain-free range of motion, teach them proper form, start with warm-up intensity, determine the appropriate exercise for them. There's where you start. Then from there, and also typically at 10 repetitions per set. From there, we want to move them across these repetition ranges in phases. The phases are typically 3 or 4 weeks long. So in other words, we want to move them once they get out of the familiarization phase. We want to start them at 12 to 15 repetitions per set for about 3 to 4 weeks and get them stronger with each exercise in this repetition range. What that does is improves their conditioning. So remember, there's conditioning, strength, power, and lean muscle tissue. This is a great way to, along with their aerobic program, to improve their conditioning. In the lower rep ranges, 6 to 8, which you eventually get to, that's the optimal rep range, or it starts to become optimal for strength and power. So what you do is you start them at 12 to 15 and you stay there for about a month. Then you reduce the repetitions to 10 to 12 and you stay there for about a month and you increase their strength in that repetition range with each exercise. Then you go down to 8 to 10 and then you go down to 6 to 8. This is a very structured way to move from conditioning through hypertrophy because arguably 8 to 12 would be optimal, or at least in my opinion, an optimal rep range for lean muscle tissue, and then down to strength. So that's a linear and uh, common sense way to progress and improve those physiological adaptations. And then these 4 smaller circles represent ways to make this program safe. The first one is to auto-regulate the sessions. And all that means is just make sure that prior to every session, you screen the person. How do you feel? How did your body respond to the last session? Did you take your medications? Are you on any new medications? Did you eat? Are you hydrated? Things like that. So there's screening questions to determine how they feel. And then within the session, you want to just continually communicate with them to make sure that they're feeling okay and make adjustments as necessary. These next 2 small circles, just represent how to create musculoskeletal safety and health to their system as you take them through this program. One is we want to balance strength, and all that means is make sure you train every major strengthen every major muscle group in your body. We want to balance flexibility. All that means is find out where they're tight and put them on a flexibility program to improve the range of motion. And we obviously want to do things with proper form. Just by doing those 3 things, you will significantly improve their musculoskeletal health. And then along with that, we just want to stay within their pain-free range of motion. And then there's just going to be precautions that you need to know, which is outside the scope of this presentation for musculoskeletal conditions. And the trainer just needs to know them and make sure that they don't do anything that conflicts with the precautions and contraindications. And then lastly, and we'll get into this in a little bit more detail in a second, but you need to insert special considerations for precautions or disease. So before I move away from this slide, let me just say that it's important for the people who are here live to understand, and for those who watch the recording to understand, that it doesn't matter how many conditions the person has. This is the blueprint. I'm literally giving the blueprint. If you do these things, you have just created a safe scenario for them from a resistance training standpoint. Adjust the sessions up based on how they feel, train every major muscle group in their body, find out where they're tight and remove those areas of tightness, and then just include the special considerations and precautions for any musculoskeletal conditions they have and any chronic disease they have. There's the blueprint. And it's the reason why you don't need condition specific programs. That was a one size fits 98% approach. And then when it comes to the indications and special precautions and contraindications, very briefly, the indications for this case study were explained on the previous slides. Auto-regulate the sessions so you're going off how they feel every single time. Back off if and when needed. Use those rate of perceived effort scales to determine the intensity that they're feeling during that session, and adjust accordingly. So those are your indications. And then also we need to educate the patient on signs and symptoms of like a hypoglycemic reaction, etc. And keep carbs handy since they are or have type 2 diabetes. And then from a special precaution standpoint with this case study, I actually should have deleted that joint pain because all I really meant to say was keep them in their pain-free range of motion with all the exercises. They might likely have they will likely have mobility issues with the knee pain, or at least there's potential here. So we need to, like, for example, we don't want exercises that have them get down on the floor and get back up, get down on the floor and get back up on maybe at all, or at the very least on a regular basis. And auto regulation again is just critical here. We need to always stay, screen them prior to every session and stay in touch during the session. And then I want Sheila's feedback here on what she thinks. But during my 10 years in the Mount Sinai system and collaborating with the cardiologist there and the family medicine, internal medicine, the physiatrist, our protocol was that there wasn't usually a need to assess pre-exercise and post-exercise blood pressure and glucose for months on end. You wanted to do it early for the first several weeks and maybe for a couple months or something like that to establish a theme. But if the theme is that their blood pressure is responding, normally to exercise and post-exercise, and they have normal resting uh, uh, blood pressure and their glucose as well, then at some point you can wean them off that. But with that said, this is also where the collaboration needs to happen because it's clinician dependent. So go ahead, Sheila, chime in on this.
Yeah, so for this, I agree. For this patient, since she had a hypertensive response to exercise on the treadmill test, I think it would be good for the initial, few sessions to have her check her blood pressure before exercising and maybe even after exercising to make sure that it's coming back down. And then glucose, I would totally skip if she's not on any medication that is potentially going to lower her glucose. But if she stayed on that medication that she's on or was taking insulin, then that's something that she is probably going to want to figure out is what is my starting glucose before the exercise session, or just make sure that she's had a meal or a snack within an hour or so.
And just a real quick FYI, and again, this is just my personal opinion. You can do whatever you want with this information, but no, safe exercise glucose range is considered 120 to 250. I don't like the 120, especially prior to resistance training, because you're gonna be using glucose as your primary form of energy. And if it's starting at 120 or 125, and it's going to depend on the length of the session and the intensity of the session, but you're tapping into glucose right away. I personally would rather see the individual a little higher than that to start. Again, it depends on how long the session is going to be, how intense it's going to be. But I actually do kind of like, at least early on, to get a sense of where their uh, resting glucose is at prior to exercise. Um, I just want to throw it. If you have any comments on that, Sheila, you can chime in. But I just want to throw that out there as just kind of from my own experience. I just sometimes, man, they're at 120, and then you notice 40 minutes into the session they're getting a little lightheaded or something like that. Well, now you have something to refer back to. Oh, okay, this makes a little bit of sense. So I just want to throw that out there. Um, in any case, contraindications for this case study for this patient is anything that's max or near max effort, especially early on. We can revisit that down the road as their fitness level improves, because this is not a static situation. Their fitness level will improve. But early on, we do not want to be doing anything that's max or near max effort aerobic or strength training, and we want to avoid the Valsalva maneuver as well, which is basically holding your breath for more than a couple seconds, especially with your epiglottis closed, because it really increases blood pressure. And then the ACSM, the American College of Sports Medicine's guidelines ambiguously say progress is tolerated, but they don't really define what that means. And I recently co-presented at the Medical Fitness Association's annual conference in New Orleans with two amazing colleagues, and one is Dr. Andrew Mott, who is board certified in family obesity, lifestyle, and preventive medicine. And his section of our presentation was on it. Well, it included, what does progressive tolerated mean? And so I have two real quick slides to talk about what that means. What it means is we all have a capacity that, and that we can with anything. And if you go above that capacity, you're now in the not tolerating it well zone, whether it's your mood and someone's annoying you, or in this case, physical exercise. So every patient, in this case, every patient with conditions and potential symptoms has a threshold that they can operate within before the symptoms occur. This is why every fitness professional should be starting with that familiarization phase. It's critical because it introduces exercise as a non-threatening manner at low frequency, low intensity, and low volume. You start with that erring on the side of caution start point, and those rate of perceived effort scales help determine their exercise tolerance. How are you feeling, and getting in tune with the talk test, their respiration, their expression of how they feel and the intensity. Yep, this is light to me. This is moderate. That you're getting that feedback, and it's really helping you gauge their start point. So the familiarization phase is critical. Um, but if something does happen, and this is one of the things that Dr. Mock talked about in the at the conference, assess the situation, educate and reassure the patient everything's going to be okay. Don't worry. But yes, you want to obviously seek medical advice if it's warranted. So that's really what progressive tolerated means. And it also means that you're going to need to modify the dose, modify the intensity, lower it, modify the volume and duration, the type of exercise. We might need to choose less challenging modes of exercises, or um, types of exercise. And then if it's a musculoskeletal issue, shorten the range of motion, reduce the range of motion to stay within their pain-free range of motion. But there's no reason there's usually no reason to stress, obviously, unless it's a significant situation. And then another thing that he talked about was keep moving. Like so many times the advice is, oh, you need to rest, 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 rest. No. And he talked about how motion is lotion, that in most cases, just move, move light, but move. The body wants to move, and that's actually going to help heal it up. And then as we wrap this up, um, there's follow-up with the clinician. That's step 6. So yeah, we're from a fitness professional standpoint, we have them on this progressive program and this clinically safe program, but the clinician is going to want feedback, and that's part of the collaboration. So I would be asking Sheila. We're obviously friends and colleagues and business partners, so we've already talked about this, but we need to follow up. What data, what information are you interested in? Um, and in my experience, is typically, are they adhering to the program? Are they seeing subjective improvements? Like, is life getting easier for them? Is their knee feeling better when they take the stairs? Things like that. But that's something that the fitness professional needs to talk about with the clinician. What do you want to know? At what cadence? Do you want to know this feedback every month, every quarter, every 6 months? What cadence do you want it? And also for how long? Because if they're referring patients to you regularly, which hopefully is the case, they're not going to want feedback on every patient forever. It'd be too much feedback. So how long do you want? And this is something that you don't necessarily talk about right away, but in your communication with the clinician, you get this type of feedback. Sheila, what are your thoughts on this?
Yeah, I mean, I think it requires a discussion. So it's an opportunity for that initial conversation for the fitness professional and the clinician who's going to be referring.
And one of the things we talked about in the article that I showed earlier in this presentation in the ACSM journal is this part of the process of building trust. Is the clinician is realizing, oh, okay, you're giving me feedback. Yep, my patients are doing well on your program. They're adhering to it. They're feeling better, etc. And it's part of that building the trust and collaboration. So the last thing is just to note that, you know, this Jane Doe situation is not static. Our body is in one of three stages, and it's really for the most part in one of two stages. It's either improving if you're doing the right thing. Maintenance doesn't happen, it doesn't stay there for very long at all, or unfortunately it's worsening. So with the adoption of and adherence to a healthy lifestyle, Jane Doe can and will improve significantly. So all those bad things that happen in the assessment can significantly improve. But without it, we all know what the deal is. And we need to really focus on fitness in order to improve her health biomarkers. So we're going to open up to hopefully no more than 5 or 10 minutes of Q&A. But before I do that, I want to at least show you the last slide. You can click on this QR code to get on our website, or you can type that URL into your um, search box to get more information. But we really appreciate you attending. And now I will open it up to discussion and questions.
Jeff, I had one question that I received, and I'm going to put the answer in the chat. The question was, is there a way to refer without email? And I'm putting a link directly to the referrals link on our website.
Good. Perfect.
We have another question in the chat. If a patient has a positive PAR-Q, what resources are there for performing a medical evaluation to clear someone for exercise?
Yeah, Sheila, can you take that one?
Yeah, I was gonna see if you had any input or comments first. Do you just, when you have a positive screen on the PAR-Q, are you contacting the clinician in general? Are you asking the patient to go get cleared and have a note, or what do you want to see?
That's a great question. You know what? Honestly, the answer is an it depends situation. That's a conversation with the but what I will tell them adamantly is, we can't you shouldn't be exercising. You need to get cleared. Like this is, I let them know that this is really important. You need to get cleared. Please do not uh, go on. It was a red flag. But that would be a discussion between the patient and I to figure
Yeah.
that out.
Yeah, I mean, usually with the case I presented, I had enough information to be able to say confidently that this patient could begin an exercise program because I had done the nuclear stress test, echo of the heart. So I feel like cardiology is a great place to send somebody like this that has multiple comorbidities, including the heart complaint. Any patient with chest pain, I think that's good practice to have a cardiology evaluation.
Are there any other? Those are great questions. Any other questions or comments? Because I know I hit you with a fire hose of info.
Yes, and we kind of went a little bit longer than we anticipated.
Yeah. Well, we started at about almost 20 of. So this is about we're at about 50 minutes right now. So yeah, it's a little over.
Well, I don't see any other questions in the chat, so I think we can go ahead and wrap up since we're at time.
Yeah. All right. So thank you everybody for attending. Really appreciate it. And we'll keep you posted on obviously it's the holidays now, so we're not going to do the next one until sometime in early January, but we'll obviously send out the emails and keep you posted on our platforms. And please join our Facebook community so you can ask questions in real time. The information on that is on our website. You can just click on the Facebook link and join our community so you can ask questions and get answers in real time. And again, just really appreciate your attendance.
Thank you all. Good night.
Have a good one.